Today I am presenting a case report on immune-mediated necrotizing myopathy. Introduction. Immune-mediated necrotizing myopathy is a subtype of idiopathic inflammatory myopathies characterized by subacute symmetrical proximal muscle weakness, markedly elevated creatine kinase, and histological findings of muscle necrosis with minimal inflammation. Unlike polymyositis and dermatomyositis, immune-mediated necrotizing myopathy lacks skin involvement and responds variably to immunosuppressants. Diagnosis involves clinical features and creatine kinase elevation, EMG, MRI, and serology that are anti-SRP and anti-HMG coreductase antibody, and biopsy confirmation. Case presentation: a 37-year-old female presented with progressive bilateral upper and lower limb weakness over 1 month. Symptoms started after an episode of food poisoning and included difficulty climbing stairs, rising from a seated position, and raising arms above the head. There was no facial, ocular, and or bulbar involvement present. No bladder or bowel incontinence was reported. The patient required assistance in daily activities like dressing and eating. On examinations, vitals were stable and muscle power was reduced symmetrically in both upper and lower limbs, 3/5 in proximal groups. Reflexes were preserved, sensory system and cranial nerves were intact. Intervention: on initial investigations, hemoglobin was 10.2 and creatine kinase on 27th November 24 was 7844. And after treatment, creatine kinase on 27th December was 236. Anti-HMG coreductase antibody was negative, C3-C4 normal, ESR was elevated, ENA panel and myositis panel both were all negative. Additional workup was done: ECG normal rhythm, normal sinus rhythm, chest X-ray was normal, ophthalmologic evaluation, no retinopathies or papilledema noted, GI endoscopy and colonoscopy normal. MRI thigh was done, suggestive of diffuse muscle edema with query necrosis. Muscle biopsy confirmed necrotizing myopathy. Management initially was started on IV steroids. Pulse therapy was given by tapering oral steroids. IV methylpred 500 mg for 5 days was given, followed by oral steroids. Immunosuppressants, methotrexate started. Supportive physiotherapy and nutrition was given. Monitoring of creatine kinase levels and functional improvement. Patient showed clinical improvement by day 7 and was discharged with advice for follow-up in medicine OPD. In this picture, a distinctive violet color rash with possible swelling suggestive of heliotrope rash is seen, and on MRI picture of right thigh, intramuscular planes with fluid collections and diffuse edema is seen. Discussion: immune-mediated necrotizing myopathy is frequently underdiagnosed due to its overlap with other myopathies. It is not always associated with anti-HMG-CR or anti-SRP antibodies as in this case. Creatine kinase levels may be extremely high and correlate with disease severity. Biopsy remains the gold standard for confirmation, and prompt steroid initiation is the key to halting muscle necrosis. Negative myositis panel do not exclude immune-mediated necrotizing myopathy, especially in seronegative subtypes. So conclusion: immune-mediated necrotizing myopathy should be considered in any patient with unexplained progressive symmetrical proximal muscle weakness and high creatine kinase levels. Early recognition and aggressive immunosuppressions are essential for recovery and functional independence. Thank you.